for joining me for the Plant Yourself podcast. I'm your host, Howie Jacobson. Hey, got a fun conversation today with two hilarious doctors. They are both emergency medicine doctors and lifestyle medicine doctors, which is about as far apart as you can get sort of conceptually in terms of when you're treating the patient, after something awful has happened or before it's even begun, whether you're dealing with sort of public health issues or the individual outcome of some public health problem. And these two guys, Sagar Doshi and Zak Hourmouzis, navigate the space with humor, with grace, with humility, and with a great deal of knowledge and respect for the scientific method that produces that knowledge. So we talked about their practice, their new podcast, CPR for Life, which stands for Columbus Prevent and Reverse. And we heard the stories that turned two ER doctors into lifestyle medicine doctors who also still practice emergency medicine. So hope you enjoy. Without further ado, Sagar Doshi and Zak Hourmouzis, welcome to the Plant Yourself podcast.
Thank you.
Yeah. So you guys are both there with high-end equipment. I was commenting earlier on your professional-looking pop filters. So you guys are also in the podcast game. So today we're going to be talking about your contribution to helping the world become wise and sane about health.
Yeah, our attempted contribution.
Very good.
Always a work in progress. Just seeing places where we can help patients.
Yeah, so why don't you guys start by
Learn
just
more and do
introducing
better.
yourselves. Sagar, you go first.
All right. My name's Sagar Doshi. I'm a physician here in Columbus, Ohio. Emergency medicine is my original specialty. And then we might discuss the story later, but I got into lifestyle medicine, got boarded in that, and now do both emergency medicine and lifestyle medicine here with Zak. And in addition to opening up a clinic together and seeing patients, we also started a podcast to try and bring out some really good, practical information on how much control people have over their lives.
Nice. When you said that, I heard mercy medicine instead of emergency medicine. I was wondering, that sounds like a really neat specialty.
Sometimes. That's more the realm of hospice.
We all need mercy.
But sometimes it's not.
Anyway, so ER,
we do
emergency medicine and lifestyle medicine. And Zak, how about you?
My credentials aren't a whole lot different, except that I'm just not boarded. Studied lifestyle medicine with Sagar a bit, but started as an emergency physician. Started getting interested in lifestyle medicine because of the changes it could make. And then, jumped on with Sagar to do our clinic and podcast, and now here we are.
Gotcha. And were you guys doing the lifestyle medicine thing independently, or did one of you drag the other one along?
Yeah.
The latter. Well, no, not a drag, but when we realized we both wanted to do the same thing, it triggered us to just say, okay, let's just do it then. So,
there was
one
Sagar
culminating
and I used to work in the
Zak.
same group in the ER. We used to work in the same ER. One of the hospitals we're at is a really busy hospital with a lot of sick patients come through the door there. We were having a relatively atrocious day where it was just busy. We were both getting beat up, and I came back to my desk, and Sagar was already sitting there. And I look at him, I'm like, man, this switching to lifestyle medicine is looking better and better every day. And he didn't really say a whole lot then, but then the next day I think you texted me, you were like, are you serious about that lifestyle medicine clinic? And I was like, yeah, kind of. I mean, my wife and I had toyed around with the idea. She's an internal medicine doc, and she's the one who dragged me into lifestyle medicine. And then I was like, So the four of us, the husbands and wives, sat down together and painted this plan to develop a lifestyle medicine clinic that's kind of turned into what it is today.
Yeah. I was just really shocked to hear anybody else talking about that. I thought I was the only one.
So when you're having an atrocious day in the ER, I watch TV shows, right? So I know it's all about, gunshots and helicopter explosions and.
Yes, that's exactly it.
Right.
Yeah. Right,
sometimes there are bombs lodged inside of people.
Right. No, what's the link between, being in the emergency room and thinking, maybe there's an upstream here? Like, what are you actually seeing on an atrocious day, and what does it make you think about?
So just to paint this picture, what is it, like a 50-bed emergency department? It's the second busiest in the state of Ohio. is where we were at that time. And so when somebody super sick comes in, they come in as an alert of some kind. A sepsis alert means somebody has suspicion of having widespread infection. A stroke alert, we're suspecting that they have a stroke. Heart attack alert or a STEMI alert, we're pretty sure this guy has a heart attack that needs to go. Something very urgent. A lot of urgent things need to happen all at once. So an atrocious day in that ED is alert. Everyone gets pulled away from what they're doing to go to this patient. Alert. Leave that patient to go to a new patient. Alert. Leave that patient to go to a new patient. Please do this simultaneously without dropping any balls. So that's an atrocious.
It's not that uncommon that happens. Actually. I don't remember why this day was particularly seemed like it was more burdensome than most. But I do remember coming back to my desk and just being like, man, like what is going on right now? Which isn't all that common, that I feel like I'm getting stretched really thin, but sometimes it just happens.
Uh-huh.
Oh, this is well before COVID. Yeah.
This was pre-COVID.
Yeah. But what sorts of things? Yeah, go ahead.
Yeah.
Sorry.
And so I saw a guy that came in, super nice guy. And he came in and he said, he's grabbing his chest and said, Doc, I'm having a heart attack. And I thought, yeah, you might be, but there's 15 other things it could be. He said, no, This is my 13th one. I know what I'm talking about. And he handed me a binder. And inside this binder was just a beautiful layout of all of his prescription medications and all the procedures he's had. And oh my gosh, how many stents there are. And so got his EKG, boom, giant heart attack. And yeah, off to the catheterization lab he went. And I went back to my desk going, 13? How do you get to 13? Do something different. And that was, unfortunately, right around the time that I lost my father, the complications of diabetes. And that just really sparked the flame of do something different. What is happening? Something needs to change. And through exploration and looking into nutrition and finding different authors and specialists, found this entire world of lifestyle medicine, which is a real board of medicine that you need to go take a board exam to pass to call yourself boarded. So it's legitimate is my point in all that. And I didn't realize it was out there, and I didn't realize that there was a century's worth of data, good data.
But as a boarded subspecial, I guess it's a subspecialty of family medicine or internal medicine, or its own deal. Like most of those, aren't controversial, right? Like you could do cardiology or you could do nephrology, and no one's like, "Oh, that's not real." But isn't there kind of a stigma that you have to go and go off out of the box to find the books? Like you're reading books that are in Barnes and Noble and Amazon as opposed to textbooks. Like how did you? Well, what is the resistance to all of medicine saying, hey, lifestyle should really be the first thing we think about?
Yeah, and I'll just push back a little bit. There are general textbooks. Right now, holding up the laptop so it's at the right angle is a lifestyle medicine textbook that is roughly this thick. So, and I've got a lot more on my bookshelf. But yeah, Zach, what do you think is the biggest resistance
I think just in medicine in general, we're taught, it's pharmaceutical based, it's procedure based. We learn things that are designed to prevent problems that we've already identified. And one of those problems typically is not an epidemiologic study of looking at what kills the most people and how to prevent that, but it's usually, okay, you have blood pressure, how to prevent the secondary step of you having a heart attack. And it's just a medical teaching. I don't think it's necessarily designed with any malice. It's just the way that medicine is taught in med school. And we learn so much stuff, and the developments for all of these new technologies and new procedures it's so robust, all of the evidence and the research that goes into that I don't think people stop and think, hey, there's probably something really simple that we can do. And then you start getting into, what exactly is the right lifestyle change as far as dietary stuff. And there's a bunch of theories with minimal evidence for the opposing viewpoints to what is traditionally taught in lifestyle medicine, in my opinion and research. But then even if you can establish that that's something that's legitimate, that should be taught, how it should be taught, then is this whole other issue where there's no big group of pharmaceutical companies or, dietary groups and, big meat or whoever with a bunch of money to shove into it to say that this is the way it should be done. So there's a lot more of a toss up for who should be leading the way here, if that makes sense.
Yeah.
Right.
Yeah, and some of it is not controversial whatsoever. If you look at the basis of family practice, internal medicine, pediatrics, even general surgery, everyone, whenever, as you brought up that example of blood pressure, sometimes they come in with the blood pressure problem. They come in with high cholesterol issues. The first step that we always learn is lifestyle change. But at least in learning it and in practice, that's where we leave it. Lifestyle change. What does that mean? No. We're on to something else now. Don't worry. Your patient won't be able to handle that, or they won't be able to sustain that. There's a little bit of implicit, I don't want to call it. Yeah, it's a little implicit bias that the thing that you want your patient to do, they're not going to do. So don't even bother with telling them to do it. Move on to the thing they will do, which is pop this pill. But the lifestyle medicine, it's in there. It is what you're supposed to do first. It's just, we kind of leave it there. At least in my training, we left it there. And it's like, yeah, just tell them to eat right, do a lot of exercise. And we never delved further. We went into the other problems. And medicine, I don't know, at least in this country, kind of got built off infectious disease, I think. And how do we stop that, right? And that is something that you can cure with pills a lot of the time, or drips. You can cure an infectious disease, and you just need someone to show up when they get sick. And now we have to shift gears completely and try to get someone to show up before they get sick and realize that this is when you need to do this stuff.
Well, so, I mean, it seems like there's also a different quality in terms of, if you give someone a prescription, you would say, like, take 50 milligrams of this pill with food 3 times a day. There's a specificity there compared to lifestyle change. You wouldn't just say to someone, hey, you should take pills. Right? But yeah,
that's true.
Some pills, some amount.
Yeah, some sort of
I don't
pills.
really know, but probably help. Right? But did you, I assume you learn how to prescribe, and there's protocols and computer programs and education around that. Whereas prescribing with that level of specificity around diet, I don't know that many doctors are trained to do that.
Yeah, but they can be. And definitely I got that from my training with lifestyle medicine, is that you can do the same thing. You want someone to eat healthfully. All right, tell them, I want you to start here. This is your tablespoon of beans for the day. And next week I want 2 tablespoons. Then we're going to start talking a can a day. Okay? So we're going to take these steps one at a time. You tell them up front, all right, this is where we're trying to get to. This is your real prescription. And then break it down into bite-sized bits, as long as we're talking about food. And the same thing for exercise, right? Exactly what kind of exercise do they need to do? How intense does it need to be? And how often do they need to do it? And what are they going to get from it? That's also important to show people.
I think.
Yeah, go ahead, Zach.
Well, I think some of it also difficult because you look at who sets the rules. So if you're in a primary care practice, if somebody's got an A1C of 7.5 or 8, or their blood pressure is X, Y, or Z, and you don't put them on blood pressure pills, all of a sudden your quality measures aren't being met. And your quality measures a lot of times set by insurance companies or CMS, which is the Center for Medicare and Medicaid Services, where they say you're not doing this, so your reimbursement rates are going to fall. And we need you to see this many patients, and this number of them need to meet these metrics. And if you just say, hey, listen, your blood pressure's been high the last 4 visits, let's work on some things. We're going to work on some meditation, some deep breathing. We're going to get you exercising a bit. CMS is going to go, that's all fine and good, but you didn't start them on a blood pressure medicine. And you're like, yeah, I know. I'm trying to get them down without blood pressure medicine.
Yeah.
Like, well, you don't meet our metrics, so you're falling out, and your quality measures are going up. Right.
So we're not going to pay you.
Right.
And so you can't pay your
So the
staff.
CMS is looking not at outcome measures, but your procedures? Like,
They look at outcome measures, but it's based on what they view as the way to get to that outcome. So they look at the path to get to the outcome that they desire. And even if you don't necessarily meet your outcomes, they go, okay, but you did the right path to get to the outcome, so that's good enough.
Yeah. There's the whole philosophy is you as the doctor are in control of this patient's health. And so you need to do these steps to make these interventions that we've already deemed as the best interventions.
Mm-hmm. And from a pill perspective, the data outcomes are better when you prescribe those medicines. That's true, but it just totally neglects trying something else lifestyle-wise.
so what's the downside of just the pills if they work, if they give you those outcomes?
So we just talked about this, actually. And then we have a podcast coming out about this. So specifically, for example, in regard to hypertension, if you look at outcome measures among people who are well-controlled hypertension versus people who don't have hypertension at all, their outcomes are actually not that dissimilar. They don't do too badly. But the problem is, you're looking at people who have hypertension are now on a pill, which side effects of pills, cost of those pills. And then typically what their lifestyles are going to predispose them to needing more blood pressure pills. And then eventually they're probably going to need other stuff too, because, they're eventually going to develop diabetes. There was just another study published recently that looked at the link between blood pressure and diabetes being kind of a comorbid condition, this metabolic syndrome we look at. So you've got now multiple things going on for which you're taking medications, but you're still predisposed as you progress through time. So yeah, I mean, if the pills worked perfectly and everybody tolerated them and there were no issues with them and they were cheap and widely accessible and people followed up with their doctors, then sure, I guess we could do that. But the reality is that the whole of lifestyle medicine aims at just more than just a blood pressure target or just a blood sugar target. There's a whole wellness component of it that isn't really quantified by a single thing, a single data point.
So for a patient, they kind of get to make a cost-benefit analysis, but right now they're not being told all the options. Right, they're being told you have to be on this pill. And my understanding for blood pressure pills in particular is that they're pretty low compliant drugs. I guess people don't like a lot of the side effects. And so you can't even get people to do that, let alone, eat broccoli.
Oh, which is sad because a lot of the side effects for blood pressure medicines, they all have different side effects. So if instead of just not taking their medicine, they talk to their doctor about better side effect profiles for them and their medicines, they might be able to switch around and take it. But still, it's just really hard to take a pill multiple times a day, every single day for the rest of your life. And so you're right, people don't do it so much. Sometimes it's only half of people take their medicines appropriately.
So you mentioned the podcast. So Zach, tell me a little about the podcast. How did it start?
When we started the clinic, we wanted to kind of reach out to people with, I don't want to call it generic advice, but advice that wasn't necessarily specific to their situation, but also try to get some of our information and our research out and our thoughts out on lifestyle medicine. So Sagar and I just basically started recording conversations that we would have some kind of data that we would talk about or some kind of research and we'd talk about it. And really what happens is one person has done the research specific to that group of time, or that period of time, where we'll talk about, for example, hypertension. We both did research on certain components of hypertension as it pertains to most recent data. And then we talk about that and get each other's reactions to it. And we just talk about anecdotes that we have and things that we've seen with our patients. And kind of try to give people a better way of living life that isn't so, okay, I know you have high blood pressure and this is your number, so this is what we're going to do with you. But say if everybody does these things, the data show that it's pretty beneficial.
And then so many people don't even know what they have, right? Somebody tells them, by the way, in case anyone's listening doesn't know, hypertension is the same thing as high blood pressure. But people get told they have high blood pressure, and that's about it. Sometimes it gets explained to them, but not in a way that they understand. High blood pressure is lots of different things. There's a lot of different causes. And unfortunately, it all comes back to physics, which can be very understandable if you put it that way. But we were noticing a lot of people coming through, at least in the clinic and in the emergency department, that didn't really understand what blood pressure means and that it's not simply a lack of medication. So if you have someone that thinks that they have a medical condition caused by the lack of medication, we're doing something wrong. So, because that's not how medical conditions occur. That's not why they occur. You weren't born supposed to be, there weren't blood pressure medicines in the breast milk of your mother. And then suddenly you came off of them and there's been a slow increase ever since there. And thank goodness we gave you back some medications. There are other things going on. There are some causes. And if we can understand why the blood pressure is going up, then maybe people will say, oh, well, that makes sense. Okay, I will do what you're talking about because I can understand. And I guess
if you're just giving someone a pill, there's no need for them to understand.
That's my hope anyway.
There's no benefit if they have no internal agency over it.
I don't know. Yeah, I still like to try and explain it to people.
I find that people tend to do better with things when they understand why they're doing things. And I think that's true of most anything. I mean, when I'm in the emergency department, there's a new order set coming through for a protocol. my first reaction is, why do I have to do this? Why? Mm-hmm. Who's benefiting from this? And if you sit down and explain it to me like I'm a child, then I learn a little bit. I'm like, okay, that's fine. That's reasonable. But yeah, in general, if I know why, I'm much more likely to be compliant with whatever the request is of me.
And I don't know if this is just our personalities, but there's a lot of, at least my initial reaction to things, and I know this is Jack's initial reaction to many things, is this, that's BS. No, prove it to me. That's BS.
My wife had to prove it to me. She's the one who put down a bunch of papers in front of me and made me believe it. When she first told me this, and I was like, that's crazy. I don't have any likelihood of having heart disease. I don't need to do any of this stuff. And then she put down papers, and I was like, oh, this sucks. Now I have to deal with this and listen to it and actually do what the papers say that I should do. Yeah.
Well, one of the reasons I really enjoy your podcast is that attitude that, we live in such a, dualistic world in which, you're either this or that. And once you have your opinion, then you're going to die on it. Mm-hmm. Right? That it's really nice to, and it's just as true in the plant-based vegan movement as it is, in paleo or keto or carnivore or anywhere else. That I just see, we just keep looking at the same data and we ignore other data. And I really appreciate that you guys it seems like you guys are just looking for what's true.
Mm-hmm.
Yeah. And sometimes that matches up with our preconceived notions. And sometimes
we were both equally
like
surprised with,
medicine.
The point that we just mentioned earlier, that blood pressure that's well controlled, it has the same outcomes as people who don't have high blood pressure, that if you do have a diagnosis and it's well controlled. We were both like, really? That can't be right. And we looked at it and like, all right, I guess it is. That's strange. All right, I guess we gotta think of,
because we gotta deal with this now.
Right.
Can't put this on a t-shirt.
Yeah. And then it comes back to a lot of, exactly. What you put on the t-shirt is, it depends. Because that's what a lot of it is, right? It depends. If you are a super healthy 25-year-old athlete and your family history is full of very healthy athletes and everyone's not getting dementia, everyone's living long, eating the same stuff that you are now, you know what? You could probably eat whatever the heck your family has been eating. And if that's pepperoni pizza, all right, I guess that's going to work out for you. But on the other hand, if you're talking about someone who's already had a heart attack or a stroke or suffering from other chronic conditions, you got to put the brakes on and start going in reverse. So it really depends on what the situation is and what the condition is.
If you guys are talking about, reading study, like for your podcast, just reading up a bunch of studies and then talking about it, compare the amount of research you have to do with like normal doctors. Like, do you do more to, I'm not really sure, like someone who's, been practicing for 20, 30 years, are they constantly like reading 5-6 new papers a week? Like what's your experience of doing research in this, in lifestyle compared to other fields?
I'll start it.
You want to take that, Zach? Because, and spin it in a way that your wife.
Should we get her on the call too?
She would be great on the call. But I think right now, if you compare us to other people, basically we're relearning things that we weren't taught. So I would say in general, we're probably reading a lot more because we're basically learning a new specialty as we go along here. It would be not dissimilar from, somebody who's, in family practice society and they want to start studying nephrology and they have to read and try to become an expert in that field all of a sudden. So I think that from that standpoint, we're probably doing a lot more reading. And then in general, I would guess that the answer would be specialty specific. If you're an electrophysiologist and you're doing pacemakers and all these strange, or I shouldn't say strange, but these, new and upcoming devices that you're putting into people and the indications for them, you're probably reading a lot more than somebody who's been practicing in a rural area where patients don't have access to a lot of, different medications, or they don't have great insurance coverages, and you're basically going what's tried and true, cheap medications to keep people out of the hospital. So I think a lot of that's specialty specific, but I would assume that people who are more highly specialized are doing a little bit more new and upcoming paper reading than others. Okay.
Yeah, and I would disagree with that based off nothing, because I haven't got any data on this, but this is my opinion anyway. Which is, I think everybody is trying to learn and keep up with everything, at least in our generation of docs and anyone close to us. I've definitely seen examples of people that have been in rural settings for many decades that aren't up on the newest treatments and what you do need to do and not need to do. But in general, everyone's trying to stay up to date, on top of the stuff, consuming whatever kind of continuing medical education that they need to, which is usually,
I think,
if you add it up, multiple papers a week.
I think that's fair. I think what I meant though is, as far as like new developing data, like if I'm practicing in the emergency medicine, a lot of the stuff that we read about is throughput information that has nothing to do with new technologies or medications. It's how do I run my department to make sure that patients are quickly taken care of and effectively taken care of, not totally not even considering medication usage or whatever. Of course, we're still doing our stroke continuum medication, CME, and STEMIs and surgical emergencies and things like that. But if I'm looking at a rural population, it's okay. How do I get compliance? Or maybe I shouldn't keep using the rural. But if I'm doing family practice, it's a lot of it is how am I getting compliance out of my patients? What techniques am I using? I don't care about the new bariatric surgery protocols. Mm-hmm. I don't care. It's not relevant to me. It's not what I do. So I think that's what I mean by that.
Uh-huh. So I mean, one of the things I've been thinking about for a while, and maybe I'm just trying to justify my own existence, is that the challenge of lifestyle medicine is prescribing things that get done. And so, help understanding, like the cutting edge is like there's something very, very conservative about lifestyle medicine in terms of, since Hippocrates, right? We've sort of understood that like lifestyle, and it's not necessarily new and flashy, like, a better color of broccoli or something. It's like very sort of low tech. Yeah. Broccoli Rob, right? Right. It's like very sort of low tech stuff. And it seems like the real challenge is saying it in a way that people are going to change. And I'm wondering, your response to that.
Yeah. Or, as I've learned from others like you, listening in a way that lets people change as well, and letting them make some of those crystallizations and realizations through their own thought process and through trial and error. But it's not just saying the right thing in the right way. I've been trying that for a long time. Hasn't really landed with most people. But when they say the right thing in the right way to themselves, that's where I could get some progress done.
So what's the practice like? Like you were talking about, atrocious days in the ER. What does it look like now? Your day to day, like
as far as
your
the
business.
Mm-hmm.
So we still work as well in the emergency department. I actually work in a rural setting, so that might be why Zach keeps harping on that. But those are my patients. Those are my people now that I take care of. And so on those days, those are those days. That's the emergency department. And when it's appropriate and then there's time for it, try to break the ice and say, hey, have you ever considered, these other ways that you might be, you want to listen to this thing? Because there's some other ways to approach this. And sometimes I hear yes, and sometimes I hear no. And then as far as clinic days, we're actually all tele, thanks to COVID now. We gave up our office. And so now it's about seeing patients over the computer and doing the same thing that we would do in the office, just nice long sessions, listening, talking, trying to figure out, all right, do you know where you need to get to and why? Well, let's cover that. And then how are we going to get there? And that's, actually kind of fun. And that's part of that's the fun and that's the frustration, all wrapped up into one. Gotcha. Is that process.
Yeah. So, I mean, what are do you have any, happy stories about people in the ER who respond yes and they want to change even in that sort of, urgent situation?
So I don't get to see people as much as my tiny community. I don't see them necessarily right away. So I don't have any success stories from the emergency department in my new community. But Zach, you've been working in the same place.
The only one that I can
still for a number of
same
years.
deal. I don't really get a chance to follow up with most of my patients, but I did have one patient who I think he came in for high blood pressure or something like that, and I talked to him about all of these things and forks over knives and lifestyle medicine and whole food plant-based diets. And a couple of weeks later, I ran into his wife, who told me that he's lost a bunch of weight and they've both been doing it and they both feel a whole lot better. And she's like, you're the vegan doctor, right? And I was like, I guess that's not wrong. So that was at least kind of interesting to see somebody actually listen to what I say. Because sometimes you just get the idea that you tell them and they're like all interested, like, yeah, it sounds great. And they go home and they go back to doing what they were doing and nobody changes, which is, I understand. I think a lot of people are all excited when you're in the ER and you're feeling something and you're there for a bad reason and somebody gives you some options and you're like, this sounds great. But then actually going home and doing it is something totally different. But then actually hearing somebody doing it was kind of cool.
So you mentioned forks over knives. I'm real curious about how you use documentaries like that. There's been a whole bunch of them from, What the Health or Game Changers, and they are not without their issues, right? In terms of they're not trying to do what you're doing in your podcast, right? They've got a mission to present a particular viewpoint, and they are curating the data. How do you use them? How do you think about them and talk about them with patients when they've got lots of great information, they're very motivating, and they might not be totally 100% unbiased?
Sagar, go ahead. Yeah, so the one, I don't really tell people to watch any documentaries except for Forks Over Knives. I feel like that one was a better, and I premise it with, if you watch this, you're going to think it's all BS, but because that's what I thought when I first watched this movie. And then I started doing research and going, oh, okay, this might be real. Right? And so I've warned them about that process that they may go through, and that at the end of that, they need to come back, either talk to me or talk to somebody who's a physician who's going to understand that perspective. And I try to refer them to the ACLM, or the American College of Lifestyle Medicine directory on lifestyle medicine doctors are out there. Because there's a bunch of people who may not be able to come back to me. I'm actually not allowed to tell them to come to me due to laws about being a physician. But they can find somebody else online and get care there. So they get interested. Maybe they do some changes, but then they're going back to somebody who can give them more unbiased data and apply it to their actual life and conditions.
Go ahead, Zach.
I view it as a tool. And you basically tell me there are a lot of cringy moments in those ones, especially What the Health and Game Changers. While I didn't mind those documentaries, there's points where you're just like, okay, like, yeah, the kid eating a big cigarette on his plate is probably not the best imagery to be like presenting yourself as an unbiased source of information here. Some of it tends to go a little overboard to me, but at least Forks Over Knives, that information presented seems to be fairly legitimate. And again, not that the other ones aren't, but that one's just basically like, hey, look, this is the diet that I'm talking about. It may be tough for you, but this is an outline of what it looks like, and you can kind of use it as a jumping off point.
Yeah. And unfortunately, I have not seen the documentaries yet that are talking about movement and connection and coping skills, stress management. If it's out there, tell me about it, because I want to watch them. I want to have people watch them. But there seems to be some documentaries from that genre.
That's really interesting. I never thought
some holes
about
that need to be filled.
The uncontroversial stuff doesn't get documentaries.
Weird.
Yeah. Yeah, it's like
ratings, viewers.
Right, our brains crave, novelty or difference. Like if I see a headline that says bacon's good for me, I'll click on it. If I see a headline that says salad's good for me, I'd probably not click on it. I don't, it doesn't add anything. So I wonder,
yeah. And you would think exercise would be controversial the way people treat it, because they're not doing it, right? So you think there'd be a big controversy about it? Not so much yes, I agree. I should be doing that. I will say very good for me.
Yeah, go ahead. Sorry.
I was going to say the difference with exercise, I think everybody knows that they need to do it with diet. It's like, well, there's this keto craze and there's this blah, blah. Everybody's agreeing that they should exercise. The general reaction is, yeah, I guess I should exercise more. And there are many people that I meet that are like, yeah, I should be eating more salad. Most of them are like, oh, they tell me bacon's good for me or butter's good for me. And I just want to, you're just slapping yourself in the head listening to this stuff.
Well, I mean, we can have debates about, eccentric exercise versus plyometric.
Mm-hmm.
Maybe we need more controversy to get people to.
I think so. I think we do.
Yeah. HIIT is the only way to exercise. I've done it now. There are no equal ways.
Tabata, do you do 20-10 or 15-15 or which one sucks?
Whatever makes you puke more, that's the one you should go for. Unless you actually have some heart disease, in which case, please talk to your doctor. Then that chest pain may not be a natural burning. All right?
And also like coping skills or stress management. Is it just because this stuff is like it's hard and it takes time and it doesn't give you an immediate reward? Like what do you find is difficult in getting your patients to begin to engage with that?
For me, it's just, I feel like people don't even recognize that they need to recognize it. It's just completely, it's kind of like the air you breathe. Is it polluted? Is it not? Who knows? Depends on where you live. I'm not even going to think about it because it's just the air that I'm breathing. So that's just the way things are. This is just the amount of stress I have. My life is hard, so that's the amount of stress I have. There's nothing I can do about it. There's nothing that needs to change or can change. And this may apply to multiple areas, but the people around me aren't dealing with it any differently than I am. So I'm not going to either. So for me, having people recognize that something needs to change or that even it can change, there are the other options, is the real sticking point.
I feel that the most common thing that I hear is I just need to relax. But there's no actual description of what that means. And it usually involves being away from people and like watching TV by yourself instead of doing getting out in nature or getting more sunlight or getting more exercise or actually meditating. If you do meditate, what does meditation mean? Do I just clear my mind? I hear that a lot too. I need to clear my mind. And I'm like, that's not what mindfulness is. That's not what meditation is. But I think we hear a lot of that. And so it's just this mantra that you hear in your head, clear your mind, relax, clear your mind, relax. But nobody really knows what that means. And I don't blame them. Nobody's been taught what that means. There's no realistic expectation that we should know what that means because we just hear those words and we're expected to apply them to be happier and more calm.
Yeah, this is a problem with pop culture, right? We've got a lot of headlines and sound bites out there without any depth to it. And that's how people are trying to figure out how to live their entire life. Or at least in terms of stress, you're right. At least there's stuff out there like Headspace and, they've got a free section. So I'll refer people to that in the ED. And then if people are actually our patients, then we actually have a mindfulness course that we offer and love to go through with people. And then we get into the actual details of what is this step by step. And at this point, I take those things for granted. And it's just really nice to be reminded of how important each step is. For example, simply being aware of what's going on, recognizing when you are feeling a certain way or when you are reacting in a certain way. When you just pay attention to the air and realize, oh, that smells nice and clean, or something is burning. Oh boy. It gives you
imagine how difficult it
is
when people say you have to relax and then telling you that relaxation actually takes work. And it's like not just going to happen to you, or how much, part of mindfulness is being non-judgmental. Being non-judgmental is really hard, and it's work to be non-judgmental, and being so. In order to do the thing that's making you calm, I have to do the thing that's very difficult. I think it's just people don't really understand that is part of the process.
Yeah, and there's so much judgment with being non-judgmental, self-judgment too.
Right.
I'm doing so badly. I made a judgment.
You jump into some mental hall of mirrors.
Get down on yourself for that. Exactly.
So what do you tell people? How might you start someone off who's the way I relax is I sit down in front of the TV or I drink or I smoke pot?
No, I was going to say, actually, I want you to take this one because you're
go ahead.
Sagar's probably our group mindfulness expert, so I usually like to defer to him on these.
I don't know if that was an oxymoron or not, but I mean, for me, it depends on what setting. If it's the emergency department, I'm trying to work with somebody in several seconds to a minute, I'll just focus on breathing with them. And I'll say, I want you to breathe like this. I'll be back in 15 minutes and we'll see how you're doing. Let me turn off the lights for you.
So what might
and
that
while other stuff is going on, and
what might that
hopefully
breathing
doesn't
look like?
time up at the same time. She's getting stabbed.
Specifically.
So I really like depending on what I think the patient can do, I'll either give them just the simple instructions of inhale through your nose and then breathe out, and make sure breathing out takes a lot longer. Or I might try something with actual seconds countings, or, inhale for 4 whole seconds, then hold it in you for 7 whole seconds and breathe it out over 8 seconds. And then do that again. I want you to do that 10 times and then do that whole thing 3 times in a row and see how you feel. If I'm not back yet, try to keep going if you can.
Oh, I feel very calm. You have a great voice for that.
Doesn't he? That's what I always say.
So as I'm rapidly saying it and then jumping out the door to go see somebody else.
Yeah.
And ignore the screaming you hear down the hall. Okay, that has nothing to do with you.
So tell me about the mindfulness course. Is that something, like a John Kabat-Zinn thing, or something that you guys have developed?
So it is both. So we've taken something that was developed by some psychologists and made it our own, which, so we put a little smear of medicine in there and some extra anatomy and some extra personal experiences as well. And we offered in 2 different ways. One is a solo way that somebody can just work through it on their own, and they're forced to only have to listen to me and Zach for so often, and then they get to work through a workbook. But then we also do a workshop course that when people sign up, they do the same thing. But in addition, me and Nina, Zach's wife, will actually talk with them, conversate with them, do a workshop and kind of work through the problems that they're experiencing. What are they noticing? What's helpful? What's not helpful? Where can they go?
Like in groups, like the people, do they see each other?
Yes. Good point. They do see each other. Yep. And everyone is sworn to secrecy. But everyone does see each other and talks to each other and can relate to each other.
Do you find
bringing back some of that
helps
connection.
people? Because I always thought that, one-on-one coaching was the gold standard. And then I did groups for, people who couldn't afford one-on-one. And I discovered that the groups often did better, or at least as well. And I started, offering group to my one-on-one clients so that they would do as well. Do you notice a group dynamic supporting people in their changes?
Absolutely. Yeah. People going, hey, that happened to me too. Or, oh, I never thought of that. What did you do about that? And just the asking of questions and learning from each other and realizing, oh, I'm not alone. We're all trying to figure this out is
there's no
incredibly important and useful.
Academia for experience. Sagar and I are not going to be the end all be all on life. We can tell you the data and how things have worked, but when you hear other people going through similar things in the actual sense of community, you can't replace that with anecdotes and teaching.
Yeah, there's an empathy that happens that accelerates people's willingness to try things.
Do you guys find that your own lives are different because you are doing this for other people? Like I was looking through the Costco Connection
100%.
magazine that we get, and there was an article by a pharmacist and it had his photo, and he looked just like on death's door, like really like an obese face, red, just extremely unhealthy. And I think that's not uncommon for medical professionals, especially nurses, but also a lot of doctors. And I wonder if you guys feel like both for integrity, but also for sort of empathy and experience that you have to live up to a certain set of standards.
Yeah, I feel like I have to model what I tell people, and thank goodness, because it's made my life better It's forced me to put effort in the right places in my life, on the right, I mean, not the right people, but the people in my life. And then eat better, move better, actually have to do what I say. And it's fantastic. And my wife has said, even if your clinic fails, all of this is for nothing. I'm so glad you're doing it because it's making everything better.
I mean, my diet was
Zach?
already cleaned up by my wife, who was a little bit stricter than I probably would have preferred at first. And I've always loved exercising. So I shouldn't say I loved it. I've always exercised, even when I've hated exercising. Yeah, but I don't always like
every
it.
Day.
And that's another thing that I like to tell my patients. So some of it's hard. I mean, a lot of this stuff, like, yeah, I don't like doing it sometimes. I don't like waking up before a 7:00 shift and going for a run. Sometimes it's hard. I'd love to sleep in. Granted, sleeping in is important, to be clear. But, you get the point. Yes.
Yeah, we didn't talk about that. But yes, I'm so glad you mentioned that.
I think that whether it's changed me, I don't know if I can say that, but I think that it's, I think I've already focused on a lot of these things, and it's given me a little bit more of a sense of, okay, I think I know what I'm doing with how to handle all of this stuff, because I've always tried to live healthy. I just didn't necessarily know how to target all of that. And I think the biggest one that I was missing was probably my diet prior to Nina making me go whole food, plant-based. And now that she ruined that, my only outlet, I have to doing that. That's true.
You can always think of another
start, just every time I get mad, I'll throw something in the wall around here or something. It'll work.
I'm sure someone has a.
There you go.
I'm sure someone has a study saying that'll help you live longer.
It's cathartic.
Yeah, I'll write the study.
Yeah. Which is one of the key parts of reviewing an article. Conflicts of interest.
Sleep is important. We haven't talked about sleep. What do you see in your patients?
Oh my gosh, so many patients have it upside down for a lot. Sleep comes last, and they want to make progress in the other areas of life. For example, weight loss or exercise. And for some of them, I say, okay, we've been trying it this way. We're making some progress. Let's try flipping this upside down and actually working on your sleep first, because 4 hours a night is really just much too short. This chronic insomnia is destroying you. It's destroying your will
and they get
to go
home
on,
from work and
your
they're like,
decision making, all sorts of things.
Yeah, I know. Because you've been sleeping 4 hours a night. It's weird.
So why are they sleeping 4 hours a night? What are some of the inputs that cause that?
TV is huge, as is the phone, as is, and here's a hard one, time with the spouse, right? If there's a spouse that's involved, and maybe you work different shifts, maybe this is the time that you can connect with your spouse after the kids go to bed, but then you got to stay awake. And then you got to wake up early because that's when work happens. That's a tough one. Or a lot of the times there's something going on as, self-medicating, be it with alcohol, and that's the time to do it, or it's with television and something happening on the iPhone, tablet that is acting as self-medication to calm their stress because they don't have another different coping mechanism.
And even coming back to some of their stuff with like the mindfulness and trying, the amount of calm and stress that gets rid, or the calm that it brings and the stress release that it causes when you're carrying all that stuff to the bed at night. And like, that's now your time to process all of your stresses while you're lying in bed, staring at your ceiling. Not a great time for it. And then when you're sleeping, you're waking up and getting bad sleep. Your cortisol spikes at 3 o'clock in the morning. People are like, why am I waking up at 3 o'clock in the morning? It's like, oh, it's probably because you're stressed. Nina tells me this all the time when she has patients that wake up in the middle of the night. She goes, is it 3 o'clock in the morning? And they go, yes. How did you know that? Yeah. And she's like, because it's circadian. Like, this is just what people do.
What is it? What is it about 3 o'clock?
It's typically when your body's starting to rev itself up, your cycle's starting to get ready, and your cortisol starts to spike. So your stress hormones that are normal to fluctuate. But if you have an over-aggressive response because you're not coping with stress, it'll wake you up and you're just ready to go and you're amped and you're like, okay, now I can't sleep.
So this is.
Yeah. And that's for people who are on a normal rhythm. If you're a night owl or a early bird.
So it seems like everything's sort of a moving target, right? So you say, well, let's not target weight loss or exercise because let's target sleep. But when we target sleep, then we realize it's actually stress. And then we could look at stress and say, well, your diet is really causing you a lot of stress physiologically. And then, so do you have
and then,
like protocols for like where to begin, or you leave it up to people, or you kind of have them, do multi-pronged changes?
So I leave it up to people once we have thoroughly investigated things on where it's coming from and trying to figure out, okay, what is actually your one area that you want to hit first. And sometimes it's the most impactful area that we've figured out, and sometimes it's just the easiest area. Sometimes it's easier just to start a workout plan or a walk, and everything else is just much too hard to deal with. But at least they can start doing something. Okay, we got one thing going. Other times we realize that, sleep is the thing. Sleep is the thing. So we got to start working on, what time you go into bed. But if we figure out sleep is the thing because stress is the thing, then we start working on stress. And it is all moving parts, and they're all related to each other, and they're all feeding into each other, which makes it a little complicated. And it's kind of nice to talk it out with someone.
Yeah, I think you have to get them
who
to
can
realize
put
that
it together.
These things are interconnected. If they just think, like you were saying earlier, the problem is weight loss, and it's simply weight loss. It's not my diet, it's not my exercise, it's not my sleep. I just need to lose weight. And you're like, well, how are we going to do that without addressing some of these things? But you have to get them to realize that, all of these things are interconnected. Let's focus on the things that are, like you said, are the most impactful, the simplest things first.
So one of the digs around the early days of lifestyle medicine was that it sounded like you were blaming the patient, right? Because if you can fix this, then you must have caused it, right? Do you have language for helping people feel like, you're not victim blaming?
Yeah, I mean, and so the facts of that are true, which is, you have this, your lifestyle integral to causing it. But I like to frame it in more of a way of, guess what? You're in charge. And so, you didn't know this stuff was going on. You had no idea. So if you didn't know any better, how could you do any better? But now we're going to start figuring out stuff. We're going to start teaching you more. You're realizing all this power you have. And now that you have the realization and you have the tools, watch out.
Yeah, I think
There's
a lot of
potential.
it is letting people...
What do you want to do with it?
I don't want to say shifting blame, but so much as letting them say, like, how, kind of we're talking about before, how is it that you would have known any of these things? When you try to search what's a good diet online, you get 15 different recommendations and, 13 of them are total garbage. Or you're told, sleep is for the weak. And, if you can stay up all the time and you can get more stuff done, or, you're told that it's normal to work 45 hours a week, still come home, take care of the house, take care of the kids, still make sure you catch up on your Netflix TV shows, and you're supposed to have time to work out. The idea of control becomes really important because these people, I think, have a sense that they have control, but really they've given up all their control to external forces in life, where if you say, these are things that we can cut out really easily that are causing you stress or eating up your time or whatever, and we can start focusing on this, it makes it a lot easier. So they go, okay, if I meal prep on Sunday, I don't have to eat 3 Hungry Mans this week. And all of a sudden their diet's that much better. You just fixed their dinner 3 nights out of, half the nights out of the week with a simple thing. So I think that if you're right, a lot of the things are decisions that we've made, but we're making these decisions under the pretense that we're in a society that values things that have not been healthy lifestyle choices, I guess.
Yeah, I mean, that's the other thing that I'm thinking is that, going back to the unmedicated, medicated blood pressure being the same as people with normal blood pressure. If you give someone a blood pressure pill, you're probably not going to materially change the quality of their existence. But I'm imagining that when you help people with exercise, with eating right, with coping mechanisms, with starting to take control, that it's not just a health outcome that you can measure with devices, that there's quality of life, that people become happier, more, have more agency over their lives, get to start making other decisions that they didn't have control over. Do you guys see any of that?
Yeah, we talk about this all the time. I mean, in the healthcare field, a lot of times we can keep you alive till you're 75, 80, 85 with relative frequency. But the question I think most of us want to answer is, are we going to be alive and healthy until we're 75, 80, 85? I don't know if it does much good if you're 85 years old and you can't get out of bed, or you're living in a nursing home, or you have dementia and you can't communicate with people you love. But if we can get you to 85 and you're active and you're able to walk around outside and take care of yourself and live on your own, the difference between taking a bunch of medications that keep your heart from infarcting versus having a lifestyle that keeps your heart actually strong and your limbs strong and your blood flow good and your brain still functioning, it's a lot different. People, I think, have this idea, if I eat a Big Mac a day and I smoke a bunch of cigarettes, I don't care if I die of a heart attack. No big deal. You're like, okay, that's fine. Valid. I'll give that's a fair point. If those things add value to your life and joy to your life, then who am I to say that they don't? However, usually what happens is not you just have a heart attack and die. You have a heart attack, you survive, but you had a stroke during that heart attack, or you just have a stroke, or you get peripheral vascular disease and you get an amputation, and now you're on dialysis because your kidneys failed in the meantime. It's not a stepwise, major step down, you die. It's this slow decline with all of these things that are adding up, and now your life's kind of miserable when all we had to do, I shouldn't say all we had to do, but the things that we could have done to make your life better were better than just the medicines would have done alone.
Yeah, people think, and I use this example frequently, but people think that life is an on-off switch, that they can do whatever they want, and it doesn't matter how bad it is for them, because they're just going to die, and that'll be it. And they got to live all their happy years as the on part of the switch until they died and it was off. But life is a dimmer switch. And the more crud you do to yourself, the more unhealthfully you live, the dimmer and dimmer and dimmer your life gets until, for the last several years or longer, it's barely on at all. And it's horrendous. I've seen people frequently who spend most of their days in the hospital or in their doctor's office or in a laboratory getting tested. And this is their life, where they live in a nursing home and they are not happy there. There are some nursing homes and people are happy there, and good for them. But a lot of people are miserable.
Yeah, most people's retirement plan is not to retire to their nearest nursing home. It's to, travel and spend time with grandkids and family and do the things that you've always wanted to do.
So let's end. I want to hear about your podcast. Like, what are the plans for it? What are the topics you want to cover? How do you want your listeners to respond?
By the way, if anyone wants to come listen to us argue with each other and say things that we think are helpful, it's called CPR for Life, and that's on any podcast distributing place, or you can come to our website at cprhealthclinic.com.
So wait, I want to interrupt you.
Link right in.
What does CPR mean here?
Trying to describe all these things. Oh,
all right.
Yeah, great point. Columbus prevent
so
and
clever.
reverse.
We're a clever
We
group.
live in Columbus. We are. Bringing back that life to the proper on position.
Okay, yes. Sorry, go ahead.
Yeah. So our purpose is to try and describe all these things to people so they can better understand it. So we've gone through, and the first phase was going through these pillars of health, these pillars of lifestyle intervention and change, like exercise and eating right and stress, and help people understand, oh, these are powerful tools and techniques that I have access to. Okay. And now what we're going to unroll in a little while is a disease by disease application of those things. We'll go into high blood pressure. Okay, what is it? What does it mean? Why do you have it? What can you do about it without meds? What meds are you actually on, and how do they work? Just so you know what the medical community is doing, why we're doing that, and what you can do to supplement that or even get rid of your meds if you do it really well. It is possible. And then we'll go into diabetes and just bit by bit helping people understand what they're afflicted with and what they can do about it and why.
Do you keep other physicians in mind as a potential audience?
So our main person that we're talking to is the person who has found themselves in the state where they are not happy with their health and they're frustrated and they're trying to look for scientific, evidence-based ways of retaking control. Hopefully there's some doctors out there too listening and going, oh, well, that's pretty cool. Oh, I could tell my patient about these other things they can do, but really it's for the person themselves.
Cool. And
no, I think that's pretty well described.
Like after that?
No, I agree, though. We won't really focus on talking to the docs too much, but I think it would be a good place for docs to, I think that I would learn something, I learned something reading about it and talking to you about it. So I think that certainly healthcare providers in general would benefit from it.
Sweet. Well, it's CPR for Life, available on all the podcast platforms. And if so, you're doing telemedicine. Does that mean anyone can see you, or it still has to be in Ohio? Is this going to change? It seems so insane.
State of Ohio, Ohio-wide.
That there's still statewide. You have to be boarded in each state, or
Yeah, it's pretty cool. No, me neither.
Yeah, I don't see that changing anytime soon.
Yeah, the state boards of medicine make a decent amount of money making sure that you spend a lot of money getting boarded in each state. So yeah, you'd have to go through each individual state.
I see. Okay.
They suspended that for a bit during COVID. I know that in certain states they were making getting boarded much easier, but I don't know if that's still going on. I don't think so.
All right, so the Buckeyes get to work with you, and everyone else will just go to ACLM.
Right.
lifestylemedicine.org, and they can search for a provider who can.
Yep, and they can search for.
Awesome. Do you guys have theme music for your podcast?
And we have a song, but it's not. It's just grabbed from Epidemic Sound. It's not like a well-known song or anything. I wish it was. It'd be cool.
Epidemic Sound.
Yeah, it's a music platform for like YouTubers and bloggers and podcasters.
Okay, I thought it might.
Mm-hmm.
Yeah,
I didn't realize that was a set you grabbed it from.
That.
How appropriate.
Yeah, hypertension music. Cool. Well,
Get you ramped up. Yeah.
I think you're offering a unique voice in the space with the humility combined with the repartee and sense of humor. It's very it's an easy pill to swallow, and it's trustworthy. So I'm so glad you guys are doing it, and it was such an honor to talk to you about it today. Any final thoughts or words for folks?
And say that people are in control of almost everything about their health. So take heart in that.
Oh, and before we go, the web address for people in Ohio who want to find out about your practice, where do they go?
CPRhealthclinic.com.
Make a note of that. Put it in the show notes.
CPRhealthclinic.com.
Zach, did you have any final thoughts?
No, I just want to echo, I guess, what Sagar said, that even if it's something like, cancer or an autoimmune disease that you were just unlucky enough to have, your lifestyle can still affect that. It may not cure it, but it can still affect it. And the things that you do will still matter.
Awesome. All right. Well, on that hopeful and positive
feel
note,
a difference.
I will bid you guys adieu. Thank you so much for all you do and for taking the time today.
Thanks, Howie. Appreciate it.
Take care.
Well, thank you very much for having us. Appreciate it.
And that's a wrap. You can check out the show notes. You can look at their practice page and their podcast at plantyourself.com/508. So movement news, getting in shape for the Ultimate Frisbee tournament coming up in April. Fire on the Bayou, going to go down to New Orleans, spend a few days with Josh, run around in my cleats. So I've been doing some sprinting. Played Ultimate yesterday evening and played on Sunday as well. So kind of tired. Just got back from Costa Rica, where I think I picked up some kind of bug, and also all the the shuttles and the planes kind of threw me off a little bit. Plus the daylight savings time didn't help. So I'm trying to balance recuperation with the urge to just knock myself out with sprints. Garden news, we are thinking about planting a early summer garden that will kind of be done, and we don't have to worry about it in August. So greens and other things that will come to fruition in July. We'll keep you updated as we figure out what those are and put them in the ground. All right, time for thanks. Thanks to Will Ridenauer for allowing me to use his beautiful song Sabali Dawn, the Dance of Peace. You can find more of Will's music at his website, willridenauer.com. And of course, thanks to all of you Plant Yourself podcast patrons. Kim Harrison, Lynn McClellan, Brittany Porter, Dominic Maurer, Barbara Whitney, Tammy Black, Amy Good, Amanda Hatherley, Mary Jane Wheeler, Ellen Kennelly, Melissa Cobb, Rachel Behrens, Tina Scharf, Tina Ahern, Jen Filikanovsky, David Bizek, The Mysterious Michelle X, Elsbeth Feldman, Leah Stoller, Alan Christensen, Colleen Peck, Michelle Landry, Josina, Sarah Durkis, Kelly Cameron, Janet Selby, Claire Adams, Tom Franzek, Jeanette Bennett, Gila Tsert, David Donahue, Blair Cyber, Dorona Vizov, Gio and Carolyn Argentati, Jody Friesner, Misha Rosen, Michael Warbeck, Aviva Lael, Alicia Lemus, Val Linneman, Nick Harper, Bandana Chawley, Molly Levine, The Inscrutable Harry R., Susan Laverty, The Panda Vegan, Craig Kovic, Adam Scharf, Karen Burry, Heather Morgan, Nigel Davies, Marion Blum, Teresa Koppel, Julian Watkins, Breed O'Connell, Sharon Hirschman, Linda Ayat, Holm Hedegaard, Isa Tuzinwa, Connie Hainline, Aaron Greer, Alicia Davis, Heather O'Connor, Carolyn Jensen, Sherry Olakoski of Plant Powered for Health, Karen Smith, Scott Morani, Karen and Joe Crabtree, Kirby Burton, Teresa Carell, Kevin McCauley, Elizabeth Rothschild, Ann Jesse, Cheryl Dwyer, Jenny Hazleton, Peter W. Evans, Dennis Bird, Darby Kelly, Laurie Fenney, Linnea Lundquist, Emily Iconelli, Levy Wallach, Rosamund McAtee, Dan Picorni, Stephen Leenan, Patty DiMartino, Mike and Donna Kartz, Deanne Bishop, Bilberry Elf, Marjorie Lewis, Tricia Adams, Nancy Sheldon, Lindsay Bayshore, Gunmarie Hagan, Tracy Gullidge, Laura Heaton, Meg from Mama Says, Stacey Stokes, Ben Savage, Michael Kay, David Hughes, Connie Rogers, Claire England, Sally Robertson, Paranganchi, Amy Daly, Brian Tourville, Mark Jeffrey Johnson, Josie Dempsey, Karen Schmidt, Pamela Hayden, Emily Perryman, Allison Corbett, Richard Stone, Lauren Vaught of Edible Musings, Aaron Hasty, Sean Owen, Sagar Naik, Erica Piedra, Danielle Roberts, Michael Lushton, Sarah Johnson, Catherine Floyd, for your generous support of the podcast. That's it for now. As always, be well, my friends.